Hello, this is Safari Sekioba with a case study on a hypertensive African American male patient who came to my clinic during my clinical hours 2 weeks ago. The patient name is Mr. J.S., who is a 45 years old African American male with a 10 years history of hypertension that was first diagnosed during his routine visit to his primary care physician. He has a positive family history of hypertension, with his mother dying at the age of 51 from hypertension-related cardiovascular disease. Furthermore, both his maternal and paternal grandparents had cardiovascular disease. During today's visit, Mr. J.S. presents for headaches and general weakness for 3 days. He verbalizes that he has been taking many medication for hypertension in the past, but he stopped taking them because of side effect. According to his medical record, Mr. J.S. is supposed to be taking atenolol 100 mg per day and hydrocortisone 12.5 mg daily. Mr. J.S. verbalized of being not aggressively physically active and very conscious of his diet, despite his effort to manage his blood pressure through lifestyle modification. His blood pressure readings at two separate occasions are a systolic blood pressure of 160 to 185, a diastolic blood pressure of 115 to 122. Mr. J.S. admitted to having difficulty to find time to exercise for more than thrice per week, stopped smoking habit as recommended by the primary care provider during his last visit to the primary care office. The chief complaint of Mr. J.S. was a headache and generalized weakness for 3 days. History and physical of the illness. Headache and generalized body weakness symptom started at 3 days ago. Both headaches and weakness are constant, have been worse since out of medication. The severity of the symptom is 5 on the scale of 0 to 10. Headache types throbbing, no alleviating/aggravating factors. Denies any dizziness, blurry vision, any photophobia. In terms of review of system, eyes reveals that Mr. J.S. has mild retinopathy as he was referred to ophthalmologist and denies any blurry vision, crossed eye, eye pain, or any discharge. In terms of ear, nose, mouth, and throat, no difficulty swallowing, sore throat, earache, postnasal drip. Cardiovascular, denies any chest pain, palpitation, swelling, ankle or legs, varicose vein, chest pain with exertion. Respiration, respiratory, denies no history of asthma, dry cough, shortness of breath, or wheezing. Gastrointestinal, denies any bleeding, any bloating, change in bowel habit, constipation, stomach pain, nausea, nor any vomiting. In terms of genitourinary, no hematuria, excessive reduced urination, kidney or bladder infection. Musculoskeletal-wise, he is positive of generalized weakness, denies any arthritis, joint pain, aches or stiffness, gout, or any muscle pain. Integumentary system, no hives, redness, lumps, wound, rashes, change in the nail or hair textures, bruising, that could also be a sign of hematologic problem. And neurologic wise, patient is positive of headache, but no blackouts, dizziness, fainting, loss of balance, loss of coordination, less of sensation, numbness, or seizures. Psychiatric-wise, denies any anxiety, depression, forgetfulness, loss of sleep, or nervousness. Endocrine, no diabetes, hot flashes, low sugar, thyroid condition, excessive hunger or thirst. Hematologic and lymphatic, no swollen glands, nose, no nosebleed, nor any bruising. Allergic and immunologic, denies any allergies or any autoimmune disorder. Past medical history: Mr. JS has a 10-year history of hypertension, denies any other medical problem. In terms of family history, father continued to suffer from hypertension, mother dying at the age of 51 from hypertension-related cardiovascular disease, maternal and paternal grandparent had a cardiovascular disease. In terms of the physical exam for Mr. JS was conducted according to this recommendation from the UpToDate. General appearance: distribution of body fat appeared to be within normal limit. However, the patient's weight is 180 and his height is 5'7", which puts him in overweight category. Skin lesion, none noted. Muscle strength, mildly weakness, but no other abnormality noted at this moment. Alertness, patient is awake, alert, and oriented. Fundoscopy exam, no hemorrhage noted at this moment. No papillar edema, no cottonwood spot noted at this time. Neck palpation and auscultation of carotid artery with normal limit. Thyroid auscultation also with normal limit. No abnormal sound noted at this moment. Heart, the size of the heart according to the chest x-ray that was done upon the presentation of Mr. JS to the clinic appeared to be with normal limit. There's no sign of cardiomegaly noted at this moment. The rhythm, it is a normal sinus rhythm. The sounds, no splitting S3 or S4 appreciated at this moment. Lung sound, there is no adventitious lung sound auscultated at this moment, no rhonchi, no wheezing. Abdomen, the renal masses, none noted. The bruit over the aorta and the renal arteries, none present at this moment. Positive femoral pauses in all of the extremities, and peripheral pauses present, no edema noted at this moment. Neurologic assessment, no visual disturbances, no focal weaknesses, no confusion at this moment. In terms of differentials, the first differential for Mr. JS, it is hypertensive agency. According to JNC7, hypertensive agency is a blood pressure that is greater than 180 over 120 mmHg in the absence of any sign and symptom of acute vital organ damage. So if this same blood pressure exists in a patient, but the patient shows any sign and symptom of damage to the vital organ, then the classification of this type of blood pressure, it moves upward into the classification of hypertensive emergencies. But if there is no presence of any sign of acute organ damage, then it is classified as hypertensive agency. Symptoms include headache, shortness of breath, anxiety, just to name a few. The next differential diagnosis is transient ischemic attack, which is a blockage of blood supply to the brain. This could be a signal of a major stroke. The next differential is coronary artery disease. This is the most common type of heart disease, and it is basically the formation of plaque into cardiac artery as shown on this picture right here. In terms of a treatment plan, the JNC7 recommend that if a patient shows up to the clinic with elevated blood pressure, basically you have to have the patient rest in a quiet room prior to initial treatment. If if the blood pressure continues to be elevated, you may want to use a clonidine 0.1 milligram or captopril, which Mr. JS received a clonidine 0.1, and then his blood pressure stabilized before he went home. The diagnostic testing, EKG was done on Mr. JS, and it revealed left ventricular hypertrophy with normal sinus rhythm. The chest X-ray, as previously stated, appeared to be with normal limit with no sign of cardiomegaly noted. Laboratory-wise, comprehensive metabolic panel show no significance at this moment. Also, the BNP is negative at this moment. The treatment plan continued. It is recommended that unless patient it is really showing any sign of acute organ damage, then the blood pressure lowering goal is supposed to be gradual. Basically, rapidity of blood pressure lowering, it is only recommended if patient demonstrate any sign and symptom of acute organ damage. Blood pressure reduction goal is less than 160 over less than 100. As stated earlier, Mr. JS received a clonidine 0.1, but over here it is recommended that you may use either clonidine 0.1 milligram or captopril 6.25 milligram as a time 1 order. Mr. JS was basically required or advised to resume his previous treatment plan, which was atenolol 100 milligram per day and hydrocortisone 12.5 milligram daily. This only and only after an effective evaluation of the side effect that was mentioned by Mr. JS at the beginning of the presentation. Mr. JS was referred to a cardiologist and a neurologist for further follow-up. Also, Mr. JS will be managed according to the up-to-date recommendation on how to manage hypertension in African American population. In terms of clinical practice guideline, JNC7 has a goal to reduce cardiovascular and renal morbidity and mortality through prevention and management of hypertension. This here, it is a classification basically, or it is telling us that you really want to manage the patient before they get into stage 2 hypertension, which is a blood pressure of greater than or equal to 160 or greater than equal to 100 diastolic blood pressure. In terms of clinical practice guideline decision making, up to date, together with JNC7, they recommend that every single patient who comes to the clinic be evaluated for prior medical history and be managed accordingly. For instance, if a patient comes in with a systolic heart failure, then the management recommendation, it include AAC inhibitor or ARD or beta blocker or diuretic or aldosterone antagonist, versus somebody who comes in with a history of BPH, which is benign prostatic hypertrophy. What it is recommended is to put that patient on alpha blocker, which has a dual function to manage BPH, also manage hypertension at the same time. The contraindication also recommended here is that a patient who has any history of angioedema should not be put on ACE inhibitor. A patient who has bronchospastic disease should not be put on a beta blocker. In terms of patient education prior to patient being discharged home, Mr. JS was provided a handout on dietary appropriate to stop hypertension. He was also provided an instruction on lifestyle modification. Also, he was provided on the instruction on how important it is to be very, very compliant with his medication regimen. In patient education on proper management of blood pressure at home, it was advised that to educate the patient to initially check for postural changes by taking any reading after 5 minutes in supine position. Then immediately um, patient may take the blood pressure 2 minutes after standing. This is really to make sure that a patient does not have any orthostatic hypertension. And also, it is advised that if patient is going to be checking their blood pressure at home, to make sure and to emphasize that the patient, they are aware of the effect of the cuff size on the blood pressure reading, because as we all know, if the blood pressure cuff size is not the right one, the reading will be abnormal. So this chart here basically it review on the patient instruction on the proper management of blood pressure at home. In terms of follow-up, Mr. JS was told to return in 3 weeks with his primary care provider, and basically implementation of blood pressure monitoring was put into place. A blood pressure monitoring log was given to Mr. JS. He was also provided with an easy communication methodology between him and his primary care provider. He was educated on sign and symptom of hypertension emergencies, and of course, the staff ensured that patient follow-up with the booked appointment it was doable. And these are my references. Thank you for listening.